Well, the elderly and healthcare are probably the most critical issue facing developed countries today. And amazingly, despite the fact that nearly a third of the population across Europe is going to be aged over 65 by 2025, it's still very low down the agenda for most governments and most of civil society. It's still not recognised as a critical issue.
Assessment of comorbidities is crucial, and also the social environment, because those patients after transplant will need some support. So here, a geriatric assessment is really extremely important.
We have to try to formulate guidelines or clinical recommendations, and especially for elderly which are in the intermediate group and in the vulnerable group. It helps you to set up a concept, which means there are 3 groups of elderly patients. One group, those are the fit persons. I mean, we even make transplants in persons who are older than 70 years when they are
Absolutely,
fit.
yeah.
So they should get the treatment which is similar to younger persons.
The new treatments we have, in most cases, are relatively well tolerated.
Absolutely.
So we know,
Things have changed.
We know now how to increase the survival of myeloma with relatively non-toxic drugs,
exactly,
of myelodysplastic syndromes, of even lymphoma, especially with rituximab. And now the problem of funding is going to come.
Welcome to the world's press here at the Hotel Fira Palace in Barcelona. Bienvenido a Barcelona. Welcome to especially the Spanish members of the press here and to all of the journalists listening online all over the world. Now, I'd like to start things off by just letting you know who's here. We are very, very fortunate indeed to have Professor Mario Boccadoro over on my left over here, an absolute powerhouse of work in hemato-oncology, and we're hoping to get your perspective on this question of ageism in oncology. Richard Sullivan next to him. Richard works at King's College. He works also jointly with the European Institute of Oncology, and Richard has an extremely interesting perspective on how to shape up the way we do clinical medicine with actual realities of politics and also epidemiology. Jan Geisler, next to Richard, is a patient, and he has in fact been very significant in organising the European Cancer Patient Coalition. He's director of that. Then Gordon McVie, who is director of, he's editor of ecancermedicalscience and the television we're listening to and watching at this very moment.
Aging populations are the most significant social issue that developing and developed countries are going to have to deal with over the next 50 years. So the issue and the social impact and the economic impact, particularly in cancer and other chronic diseases for the aging population, is absolutely vast. There are lots of new agents coming down the pipeline with improved toxicity profiles, better toleration, and we had a roundtable discussion of experts earlier today, and one of the key issues here was how you deliver treatment to patients outside the hospital in the community. Ageism does exist in clinical trials and clinical management in AML and MDS. You can no longer consider patients, when you look at the literature, as being frail based on chronological age. It is a question of biology. They would like to see more elderly patients featured in hematological clinical trials. And this is, again, a very, very key issue that we talk very easily about new treatments and how to treat the elderly, but you can't do this unless you're actually including them in proper clinical studies. And so in terms of recommendations that came out of the qualitative interviews, support research into the validation of tools to assess the frailty or the biological age of patients rather than the chronological age, improve social policy issues to support patients in terms of isolation, poverty, and also in terms of patient group support.
I think that we have to move to another culture to treat the elderly patient up front, not at relapse, because the advantage that you can have is really limited. And if you are treating upfront, you are prolonging the event-free survival. I mean, you are not curing this group of patients, but we are prolonging survival. We have to change totally the concept of frail. First, because of the tolerance of the new drugs. And second, we need tools to evaluate what it means for 80. If you are able with the newer agent to double the survival, they are really active, really not toxic. We have, thalidomide, lenalidomide, and Velcade. These true new agents are all three very, very effective, and the toxicity in comparison to the old chemo, it's totally different. Really well tolerated, particularly the newer one. Just supportive care therapy is not enough for our elderly patients.
Only about 7% of these patients would die of CML if they were properly treated. And that is independent of the age, because this treatment works on every age group. There's no difference in that. And there's also no difference on comorbidity. So if this patient would have a different other disease, it wouldn't impact the cancer treatment.
We are trying to say, look, this is absolutely unacceptable. It's unacceptable now, and it's going to be a crisis of unacceptability in 10, 15 years as the number of patients getting cancer over the age of 65, over the age of 70, over the age of 75, over the age of 80, just goes up. We need to do more clinical trials to work out what's the best way of tackling this impending crisis. This is an issue of discrimination, and if this was sex discrimination, if this was racial discrimination, if there was discrimination against AIDS patients or homosexuals or whatever you like, you would be upset about it. Well, I am saying this is discrimination against older patients who've got cancer, so write about it.
It's a lot about communication, and of course in terms of trials, it is very important that cancer clinical trials, that they give also patients at that age the option to join trials if there's not a good reason against that.
The key messages are firstly that ageism in cancer should be outlawed completely, that this is about the biology of the cancer and the biology of the patients. It's not about the chronology in age. And secondly, there needs to be a lot more focus on the issues surrounding the social policy of patients, both during the treatment phase and also as survivors, in terms of social support for within the environment, and also social support for those individuals who are most vulnerable.